This is ASAP Pathway. Welcome back, everybody, to another episode of ASAP Pathway, the podcast. I'm your host, Dr. Stacy, and very honored to bring our guest today to you all, Dr. Keith Matheny. Welcome, Keith.
Thank you. I'm finally here.
We were just talking about when did we schedule this? It's been a minute. And then the holidays happened, and
As
um,
they do.
yeah, so it all, life happens. It gets the hustle and bustle of the holidays, and here we are.
Here
So
we
I'm
are.
so excited. I've just seen you, in social media. I've crossed over people that know you, and I was talking to KPD with, Karen
Yes.
Parker Davidson, and she told me, well, you know where I get my name KPD? And I said, no. And she said, Keith Matheny named me KPD.
Yes.
And then it was like, okay, this is another sign. I gotta talk to Keith. So then we were like, let's just do it.
I
Let's
am a
have a podcast.
nicknamer. Yeah. So yeah.
It's a
If
mouthful.
I
She's
love
phenomenal.
you, if I love you, you're gonna get a nickname. Yeah. Yeah. Her
That's so
name is
great.
a mouthful, but she's an outstanding
Oh,
person
she
and
is. She
so
really is.
passionate about things that you and I are passionate about. Yeah, she's amazing.
Yeah, I got to know her just, well, no, I can't say this year, 2025. I'd heard about her, and I'm just blown away by the things that she's come up with and how her mind works. And I do feel like she's got a missing piece of the puzzle. I really do. We don't talk about the function as much. We are very structure based in dentistry, but function and aerodynamics and resistance. She's fantastic. As a matter of fact, I had her on. For those of you listening, she was on a few episodes ago, so check it out. She's affectionately called the Nose Nerd by Mike DeLuke, which I think is a great nickname for her too.
Oh, she loves it. Yeah, she
Yeah.
loves
So she's fantastic. But so are you, Keith, and that's why I wanted to have you on. So for people that don't know who you are, I would love to do an abbreviated introduction of you, if that's okay. And then you and I can dive in. We pretty much had a podcast before we even hit
Yeah,
record.
yeah. I know we should have hit record a while ago.
We should have hit record a while ago. Okay, let me get started here. So Dr. Matheny, he is a Vanderbilt-trained otolaryngologist in community practice for nearly 25 years in North Dallas, emphasizing rhinology and sleep. He has a passion for the business aspects of otolaryngology as well as new technology, pharmacotherapy, and procedures in ENT. He holds dozens of patents on bioabsorbable local drug delivery implants for use in sinus and ear surgery, founding two device companies around these technologies, Septum Solutions and Otologic Solutions. He's also the founder, chairman, CEO of US ENT Partners, an ENT focus group purchasing organization bringing significant savings to physicians on the high cost supplies that they use in their office daily. He also co founded Sleep Vigil, a company pioneering the concept of remote patient monitoring for sleep apnea. He has authored numerous journal articles and has given hundreds of presentations on his clinical research and on various topics related to the business of medicine over the last few decades. As a creative outlet, he has commercialized a barbecue seasoning and hosts various social media pages dedicated to his grilling and cooking. He volunteers in his community, providing charity clinics for multiple school districts around his practice, serving on the local YMCA board, and as an otolaryngologist for the Dallas Cowboys. You're a busy man.
It's man, but I love it. I love it.
Well, I personally follow you on Instagram, and that would be, and I'll put all these links, but grill underscore Dr. 14, right?
That's right.
He's
That's
the
right.
grill doctor, and he makes some delicious food. And then I always see what you make, and then I'm like, ooh. Then I look at what I have to make for dinner. I'm
Well, I
like, oh,
absolutely love that. And that is, we work hard, right? And so it's so wonderful to have an outlet like that that's outside It's good food. It's good social activity. I mean, I love it. So thanks for mentioning that too.
Absolutely, absolutely. I think, you know, a lot of times people see us in our practices and they think, you know, our lives are completely that, that's who we are. You're a
24/7 looking
dentist.
at a microscope. Yeah.
Yeah, we sit and look through, and I love my microscope, by the way. Do you use microscopes?
You
Are
for
you a global? Are
years.
you a Zeiss?
Yeah. Well, I have to be very, I have partnerships with both at USENT, but yeah,
Okay,
but
there we go.
we're blessed to have nice Zeiss scopes in our office. Yeah. Those things last forever. I mean, one
They
of
are.
the
They're
Zeiss
amazing.
scopes was purchased by my founding partner probably 50 years ago, and I think it was used then. And it's still, the optics are still perfect. So it's hard to beat that.
Yeah, those are, I'll give a shout out to Global Scopes. I've had my scopes. I have my original scope. So all my dentistry is under a microscope. And I started it right when I got out of dental school. And I started it
So 3 or 4
because
years ago, that's
3 or 4 years ago. Yeah. I knew I love you, Keith.
See,
It was,
my nurse knows, or my patients know, because I'm constantly talking about cooking and we're sharing pictures. And so, they have to bring me back actually to the clinical. So there's no surprise. And then my patients don't think I do this 24/7 because we're always talking about
you're
other
always talking about grilling and food.
shit. And the Cowboys' woes for the last 30
Oh,
years. And
oh yeah. Oh yeah.
then we eventually talk about medical things too.
Yeah. Well, you know what? That was where I was going, is I think, a friend of mine posted, Jason Tierney, he posted something the other day about authenticity and how important it is to bring authenticity to your relationships, personal relationships, professional relationships, your marriage. You know, it's just such a gift to give your authentic self to somebody. And you're not going to be everybody's cup of tea or coffee or shot of whiskey,
Right.
you're but you know what? It's life's too short to be somebody else and pretend to be somebody else. And I think patients appreciate that when you are
Yeah.
having these organic conversations. You're a real person with a family, and we have passions
You
outside of
just
it.
relate to them. I mean, I have believed for a long time that, when you have a slate of 30 or 40 patients on your clinic schedule, that's they're not there by accident. There's a reason that they're there, and it may or may not be medical. Sometimes they need a listening ear, or sometimes they need to have a escape and talk about grilling or football or something like that. Our job is, I view it at least, much beyond what our stated craft is. We're really there to listen to these patients and to interact with them. And that starts, like you said, with being authentic, with being transparent, for sure.
Well, I think what is, I'm so excited to have the conversation we're going to have. I think our professions, when you look at, ENT and dentistry, we're kind of um, our playgrounds overlap each other, that's for sure,
Oh yeah.
more than most professions. And yet we have these kind of a lack of collaboration. We should be collaborating a whole heck of a lot more than we are, considering our playgrounds are literally in the same area. And what I can do can influence some of your therapies, and definitely what you do can influence some of my therapies, and
Yeah.
vice versa. But so, you know, I find it interesting, actually, when you and I were kind of prepping, like, what are we going to talk about? Because there's so much to say. And I was texting you a situation that I had had that week where there's just a lot of sleep physicians out there that I don't think are having enough discussion about nasal breathing and nasal function. And
Even
they'll,
even as ENT physicians, I find myself and so many of my colleagues, we're guilty of zeroing in on the throat and where the obstruction's actually happening. But the obstruction is the end result of probably issues, both anatomical and functional elsewhere. I know,
Okay. On
I know,
that note, like,
KPD is probably cheering hearing that, but it's true. And yeah, the nose is, well, the way I say it, the nose is central, literally, but figuratively in sleep disordered breathing.
so
And
what do you say
we
to the
have to look
sleep
at it.
doctors that, okay, I get this a lot. And I had a guy today. He came to me for a sleep device. He's CPAP intolerant. He struggles breathing through his nose. We did the Cottle. I asked what he had done in the past, ENT wise. What have you had done structurally? He said, I don't know. I might have turbinate reduction. My septum's, not too bad. The ENT said it's not too bad. But the sleep doctor told me, it doesn't matter what they do to your nose. Your apnea isn't going to get any better if
Mhm.
they do something with your nose. And, I've seen studies on, fixed obstructions versus like soft tissue obstructions and how, fixed obstructions tend to have less of an effect on AHI. So you hear the old literature rolling around,
Mhm.
and then people just make these blanket statements that the nose doesn't really affect apnea.
Yeah.
What do you say to
Yeah.
that?
Yeah, it chaps my hide really because you said the most important thing right off the bat. He's CPAP intolerant.
Yeah.
Well, why? Most, at least, almost all CPAP is delivered at least partially nasally, right? So if you have nasal obstruction, whether it's fixed or functional, and what we mean there for someone that may not be familiar is your nose may be fine at rest, but during inspiration or expiration or some other action, it becomes blocked. Usually that's due to floppy cartilage or something mobile in the nose. That's probably why they're CPAP intolerant.
Right.
So, what to say, well, because you're CPAP intolerant and the nose isn't important, I mean, that's an oxymoron, right? So it's absolutely important whether the patient is going to be treated with CPAP or oral appliance therapy, even hypoglossal nerve stimulation to make sure they have a patent nasal airway. And I'm not trying to do more procedures and surgery at all. We're trying to get these patients treated. And we haven't even talked about the fact that most patients need multi-level treatment, the nose almost always being one of them. So yeah, collaboration is in order here, and I don't mean just dentists and otolaryngologists. I mean the pulmonologists, the
Yes.
neurologists, everybody caring for sleep. We have to work together collegially and uh, as a group help that patient. And the nose is almost always one of the spots. Almost.
Always, always. It's funny, and I find it interesting that when I have a consultation about whether it's a kid, a pediatric patient where parents might bring their kiddo to me, CPAP intolerant, or they just aren't sure if they want to do CPAP, or sleep physicians referring a patient to me that is, they're CPAP intolerant, and they're like, "You're having more of a discussion about my nose than than most people." All the healthcare providers I've gone to, I'm like, why is that? Why? It's just, to me, it's such a logical thing that we would talk about
Yeah, I think it's
the
maybe,
nose.
you know, where we see deficits, where I see deficits in my physical exam, it's if I don't have a way to help the patient, I think it's easy to ignore it. So you mentioned the Cottle test a second ago. So for those that don't know, that's a test to measure how lax or how weak the cartilaginous support is for the tip of your nose. And what you do is you put some kind of rigid instrument, usually a small suction or a little loop that we clean out earwax with, and just gently support the soft tissue of the nostril and have the patient breathe in. And if they notice an improvement, that's a positive Cottle maneuver, meaning that if you just gave them a little more support, they would feel better airflow through their nose. Well, we now have some really simple office procedures to handle that, but only over the last 10 to 15 years. There's some radiofrequency treatments, there's a bioabsorbable implant that we can put in because it used to require a large functional rhinoplasty. And a lot of times that was a cash pay proposition. So because we couldn't really offer options to patients, even as otolaryngologists, we'd blow right by that, not even make that part of our physical exam.
Yes, I hear that a lot. The nasal valve is the first point of collapse in the airway.
Yeah.
And
The
the
stats
first
used
thing
to
you do
be,
is put a speculum in there and go
right.
right past the nasal valve and look at everything else.
Exactly. So you're fixing the nasal valve collapse by putting a speculum in. Well, even to the point that, the board answer for how much nasal valve collapse is out there was something like 12, 13, 15%, until we started looking and realizing that almost everybody in their 40s and 50s and older has it. So it's much higher than 15%.
Why is that? Is that like a later in life?
We just get floppier as we get
Yeah,
older.
sure
And
thing.
yeah, you'll
Yeah.
see. You'll see.
Oh,
So the nose is not exempt from that.
yeah, makes
And
sense.
half of our nose is soft tissue. It's cartilage and just skin, subcutaneous tissue. So gravity works. Gravity is undefeated. And that's true even of the nose. And that's just the front hallway, right? The patio of the nose. Then there's a whole host of things inside the nose that can be obstructive that you cannot see without a scope and without CT scans in a lot of cases. The nose is a structure, and you know this, but a lot of our colleagues maybe have forgotten from gross anatomy. The nose goes back halfway into the head from every direction. It's not just a little piece of tissue out on our face. And so the obstruction in a patient that's intolerant to CPAP could be 2 or 3 inches posterior. And I can't see that. And I've been doing this for 30 years. And so certainly another person that's not comfortable looking in the nose with the right instruments can't see that either. And so again, it's imperative for us to thoroughly evaluate the entire airway, which includes the nose, in someone with a sleep disordered breathing situation.
Well, something you said before I hit record, and I was so glad you said it. A lot of times for, ENT evaluations, when it comes to the septum, there's, you know, would be considered like a fixed obstruction, that bone.
Mhm.
I don't hear a lot of septal swell body discussions.
Yeah.
And that's the soft tissue aspect of the septum, which, can be inflamed as well. So you'll see, deviated septum or no deviated septum, turbinate hypertrophy, then you can go into adenoids and different aspects, but I don't,
Yeah.
once in
Nasal
a while, I'll
polyps.
see the septal swell body discussed but not a lot.
It's relatively new. I mean, obviously, it's been around for millions of years.
It's a new feature.
Yeah, yeah, this is not a new evolution here, but uh, we've talked about it, I would say, less than 10 years, probably closer to 6 or 7 years in our literature and in our meetings. I'm talking about in ENT. And, even as a young physician, as a resident, we always used to look at CT scans and see the top of the septum. So it's in the cartilaginous part, like you mentioned. So the anterior half of the septum. It's two humps that stick out, one on each side. And some people, sometimes even the radiologist, will read those as a deviation, but they're really not. They're turbinate tissue. So just like on the lateral wall, we have usually three turbinates. Some people have four, the inferior, middle, and superior turbinates. And they're big sponges. It's actually erectile tissue. And so that's why people that say, doc, if I lay on my right side, my right nostril gets congested and I flip over and that opens up, and then the left side, it's just a big sponge. Well, we have that same type of tissue at the top of our septum. And as such, when you have an allergy attack, a cold, sinus infection, what have you, that engorges as well and causes further obstruction. So when we treat, and we'll talk about probably some of the treatments we have, like the radiofrequency options we have, we don't just treat the nasal valve cartilage or the turbinates or the nerves coming into the back of the turbinates. We also treat those swell bodies.
Hmm.
What I mean by treat, using the heat, we destroy some of that spongy tissue, which over time shrinks it and shrinks the capacity to swell, thus opening the airway. And again, quoting KPD here, every millimeter in diameter that I improve the airway, the patient feels that to the fourth power.
Gosh.
The laws of aerodynamics. So it doesn't take much
Mm.
to make a meaningful impact on a patient from their perception of breathing. And I would extrapolate that too to someone you're trying to get to tolerate CPAP. Or if you're treating with oral appliance therapy and you're not quite there, that may be what gets them over the edge to get them into normal ranges with normal oxygen.
Have you seen any, just anecdotally, when you do that, and I'm thinking of, the Starling resistor model for
Mhm.
those listening, that means basically if you have a fixed tube at one end and a fixed, a hard structured tube at one end and a hard structured tube at another end, but then in between connecting that, you have like a flexible picture, like a balloon or something in the middle. So that would be your nose at one end, and then we've got the trachea at the other end. Um, but then in between, we have all this soft tissue, which in that model, it makes sense that if you can increase flow upstream, you're going to decrease collapsibility downstream. But a lot of the research is nope, the nose does not affect AHI. The nose does not affect apnea or sleep related breathing disorders. What are you seeing when you actually are changing and increasing that? I mean, just because the studies aren't there doesn't mean it isn't. We
Yeah,
just
we're
don't,
really, yeah, the onus is on, my specialty to get better data, but we do see that when we improve the nasal airflow, for sure, we can at minimum turn down the CPAP pressures,
that makes sense.
or we can get that oral appliance patient, maybe we got their AHI down from 20 to 10 to 8, but they're still having significant hypoxic burden. Once we open up the nasal airway, then usually we get them right into the sweet spot of
Hmm.
management. So we definitely see that anecdotally, and we need to show that objectively better.
That'd be
And
fantastic because I just think there's a lot of data and information floating around from years back. I think too, you talk about the radio frequency. So if somebody goes through a procedure, that kind of procedure, I
Mhm.
mean, it sounds like that would be very little downtime.
Yeah, really, they're so easy. They're done in the office, which again, that's another thing that I think otolaryngologists finally are learning from our dental colleagues is how much you can do in the office comfortably.
Yeah.
Uh, I guess we just came up taking everybody to the operating room, and so it's been a fairly slow transition. Thankfully, we've transitioned now into the office for these things. But yeah, those radio frequency procedures, for example, we use topical tetracaine anesthesia. Again, I personally borrowed that from my own dentist and published that 15 years ago. And now it's a common way that my colleagues and I do all kinds of nasal procedures because the nasal mucosa reacts just as well as the oral mucosa to the tetracaine gels. So we usually don't even have to inject anything. And the nose is super sensitive. But these patients are really comfortable. The radio frequency devices are probably about 60 degrees Celsius at their maximum heat. So they're hot, but not intolerably hot, especially with the tetracaine anesthesia. And we typically, a patient is numb in 15, 18, 20 minutes. These procedures take 5 minutes or less. Um, we cause a little bit of congestion, and patients mean two things when we say the word congestion. Sometimes they mean snot, mucus, all that stuff. Sometimes they mean blockage. When I'm saying congestion, we cause blockage because the tissues swell after the heating. But for 2 or 3 days, we don't see bleeding. There's not really pain, bruising, any of those things. And then the patients are improving almost day by day after that from an obstruction standpoint, and also we use that same treatment for chronic postnasal drip or runny nose. So we can kill several birds with one
Hmm.
stone.
What is the bracket, the age bracket? What's the youngest that you would do a procedure like that with the radio frequency?
Yeah. For the turbinates, for example, I
Mm.
mean, we would do it even in the pediatric population. Um, for chronic rhinitis, the postnasal drip, that tends to be more prevalent as you get older, as you get more mature. So in your 40s, 50s, and older. But no qualms, it's actually a very safe procedure. There are three or four instruments we could use in the pediatric population, at least to reduce the size of the turbinates and the swell bodies for that matter.
Well, that is so transitioning a little bit to pediatrics. We talked before we started the official podcast, just kind of a wish list, if you will.
Mhm.
And so a wish list for ENTs, a wish list for dentists, like what we would love to see happen. But I see so many kids and, mouth breathing, nasal obstruction in children, this is where the craniofacial developmental issues can happen that lead to this long road of poor breathing because they're developing vaulted palates, they have low tongue posture, you know, um, they're just fragmented sleep, mouth breathing, not doing well in school, they're snoring, the jaw's dropping back, more obstructions. And I get these parents that come to me and they're like, why can't my child breathe through their nose? And, when talking to other ENTs, they're like, look, we're not doing surgery on a child's nose. We're just not going to do it. So, um, the things we talked about earlier, what is it? This is the question I get all the time. Parents are like, why is my child breathing through their mouth and not through their nose? So we might see, like, if I take a CBCT, I might see really enlarged adenoids. And I'm like, okay, they've got a giant speed bump, behind the nose.
Right.
So, there's a path of resistance there. So they're going to go path of least resistance and start mouth breathing. Why on earth are we seeing so many kids with increased turbinate size, mouth breathing, allergies, inflammation? What do you think? What the heck is going on here? And I'm happy to hear that there's a solution because the literature right now is Flonase and different medications, and it's just sometimes that works, but I see all the kids that it's not working in.
Right. Yeah, it's always good to try those conservative things
Yeah,
first. And to some extent, you can outgrow at least adenoid enlargement by your adolescence, but that's a long time to
it's a
sleep
long
poorly.
time to
But
suffocate.
you-
It's a
to
long time to.
suffocate, the die is cast, like your palate is going to be arched. Your face, I mean, if people are familiar with adenoid faces, if not, just do a quick Google image search and you'll say, "Oh, I know 50 people that look like that." And that's what happens with chronic mouth breathing. Besides, if they do have sleep disordered breathing, they're probably behaving like an ADHD child. So not learning, not performing as well as they could in
Right.
school, accumulating all those labels as a difficult child, whatever, on and on and on, when you could have intervened potentially much earlier. So yeah, I would look at that child as you do, Stacy, and evaluate with a CT, which is a very minimal amount of radiation, especially for the benefit that you can find. Look at their adenoids, look at their septum. Yeah, you're not going to probably operate on the septum until the kid is done growing, or at least until they're 16, 17, for fear of throwing off development. But you can still help them with their turbinate size. There's something about the human body that we perceive that we're breathing better if we ventilate our maxillary sinuses. So if that child is also having some sinus infections that are documented, you can use a small balloon to open up the maxillary sinuses. There are so many things that you just don't have to wait till the kid is 16, 17, 18 for all the negative effects we mentioned a minute ago. There's a lot that can be done.
Well, we hear the whole, wait till adolescence, those tissues may shrink. But the problem is now you have years of either hypoxic burden, sleep fragmentation, executive function issues, behavior issues. So it's not like they're growing into problems, even though they might be
Right.
growing eventually out of big adenoids. It's kind of the damage was already done. So
Yeah. Well, I
we,
have so many. I mean, we talked about some of my patient examples. This is one I didn't share with you. I have someone I saw probably she was late in high school, and her tonsils and adenoids were large, and she had, I mean, a beautiful girl, but she had the adenoid facies, so those dark circles under her eyes, kind of a long oval face. She was an only child, and I remember both of her parents came to that appointment. And it was pretty early in my career, so I was still pretty green. And she came in, they kind of snuck in, um, without telling their pediatrician who had had her as a patient since she was born, just to talk about tonsils and adenoids. And, through the discussion, she also had asthma.
Mm,
And the whole family just revolved around this mouth breathing and her nebulizers every 4 hours and all this stuff. And she was literally 16 or 17 years old. I can picture her face right now. She's probably now 40, 45. But we decided to take out the tonsils and adenoids. And she did a great job with recovery. It's a little bit tougher in adolescence and adulthood than younger kids. But they came in for their first post-op. That's back in the days when we had the luxury of seeing our patients post-op. Now my PA does a great job doing that, but I don't always get this immediate feedback. But I saw her in her first post-op appointment, and the family, I mean, they were in tears. Said, we put the nebulizer, I asked, how's the recovery? And, was worried about her pain and things. If she had any bleeding? They didn't even mention that. Said, we put the nebulizer up in the closet for the first time in her life.
mm.
And she's sleeping and she's eating, and she feels better even with the sore throat than she has her entire life. And so I learned, I mean, they were happy, but I think we all recognize what a tragedy that we were doing that late in her life. Um, so yeah, on my wish list, if we're going to talk about that, and I'm fortunate to have several excellent pediatric dentists and general dentists that see peds in my uh, catch area, who they're usually the ones, or they're often the ones, I shouldn't say usually, in conjunction with pediatricians that are sending patients over to consider tonsils and adenoids. And a lot of times we don't move forward, but sometimes it's just such a slam dunk. You think, how did this kid make it to 6 or 7 years of age and no one mentioned this? And it's life-changing for them. My mother was a first grade teacher for 40 or 50 years, and she saw it from a behavioral perspective. At that age, 6 years old, a lot of kids are hyper, right? No matter what. And nowadays, certainly the last 10 or 20 years, so many of these children have the diagnosis of ADHD.
Yeah.
Well, is it always ADHD? And she saw it every year. Once she knew I was going into ear, nose, and throat, she talked about how so many kids that had their tonsils and adenoids out during winter break were completely different behaviorally in January compared to how they had left at the end of the semester in December. Just being able to sleep appropriately.
Mm, that alone.
Plus all the beneficial effects on their orthodontia too. So yeah, there certainly are reasons to look for this. Maybe 50 years ago, 75 years ago, tonsils was just kind of an automatic thing, and it's not an automatic surgery, but it's certainly something that needs to be on our radar screens.
What would you say? I get this a lot too. I'll get parents. I had a consultation with me, let's see, probably 2 weeks ago. They had been to the ENT. At that time, the ENT said, I don't see any issues here. The kiddo has been diagnosed twice with OSA, two PSGs, still mouth breathing, um, crowded primary dentition, which means no spacing. So that is crowded. Your baby teeth should have big. You should be able to put slot a nickel between each tooth.
Good, I didn't know that. Well,
Yeah, it's so, and it's very rare these days when you look at a kid's mouth. I mean,
yeah, you
you
never see
think
it.
that there's no spacing. Those adult teeth are a whole lot bigger than those baby teeth. So what looks beautiful and cosmetic with no spacing in a 4-year-old is crowded. Already they're deficient in bone. They're already deficient.
Well, I mean,
So
that's
it
something
doesn't get
I'll
better.
start looking for right away. Yeah, that's
Yeah, just that
key.
alone is a malocclusion. And what's interesting, Keith, is like there was a paper written 100 years ago by an orthodontist who said what, and it shows this drawing of, primary dentition baby teeth with no spacing versus with spacing. And his point was, looking at hundreds and hundreds of kids over the years, it never gets better. They don't grow extra bone. But the biggest question you should ask, so the malocclusion worsens, it doesn't ever correct itself. So you really need to intercept and create more bone for those teeth. So there was a hiccup along the way with growth and development. And his point being, collaborate with your ear, nose, throat doctors
Mhm.
because you need to ask not just, oh, look, there's a malocclusion, but why is there a
Yeah.
malocclusion?
Wow.
And addressing it right away versus, it used to be, okay, we don't even do anything orthodontically till the kiddo's 12, 13, 14 years old because we want to wait till all the baby teeth are gone. They're looking at it the wrong way. And it just kills me because we're still beating the same drum and it's been 100 years. So it's just like this is why
I think that's the lack of collaboration. I
that's
trained,
exactly right.
I mean, when you introduced me, we talked about Vanderbilt. Vanderbilt is, I mean, perennially ranked #1 in otolaryngology training. I was so blessed and fortunate to train there. But we, in no other residency program, to my knowledge, have any training in dentistry. I mean, when we interface with teeth during our training, it's in a cancer case, and we're cutting out part of the mandible, right? We're cutting out part of the maxilla, the palate. So, and I would presume that a lot of what we learn as otolaryngologists is not taught in dental school. I don't know that, but that's right there. I think that's where the lack of collaboration
Hmm.
starts. Is that, oh, okay, I'm getting to the ear fence, which is the teeth. So I don't know anything there, literally. So I'm going to send you to this person, and vice versa. And we're doing a poor job at, first of all, screening and identifying to make proper referrals, and then actually following through. I mean, obviously, you and I believe strongly, and we'll talk about it in collaborating in sleep care, but even just in general pediatrics, we must be much better
Well,
at.
agreed. And it could start as early as training in our school systems, our residencies. And
Yeah,
it's
I mean,
funny,
why would we not rotate
why
through?
wouldn't we? Why wouldn't you have medical
Yeah,
students, ENT residents visiting with dentists? I mean, like, why wouldn't we? Why wouldn't we have dentists
I know.
understanding
It
better
seems
what
so simple. Yeah. I mean, just think about even, the dentists that focus on mucosal pathology, right? The myriad of lesions that can happen in the mouth. I mean, how good would that be for us to have collaboration there during our training and then really throughout our careers instead of just sending patients back and forth? Um, yeah, I mean, when we talk about the medical dental collaboration, you and I and Jason and all the people you've mentioned, we're usually talking about dealing with sleep apnea. But I think it could be much bigger than that.
Oh, agreed. Agreed. I mean, just even what you were saying, what drives the growth of the face? I mean, the nose is driving the growth of the face. And, you know, it's like you said earlier when we were talking before recording, again, the chicken or the egg. You've got an ENT problem, but you also have a dental, facial, orthopedic, craniofacial problem. We know that tonsils and adenoids aren't curative of OSA in a lot of kiddos, and especially like, the non-obese child,
Hmm.
when you have an OSA issue, you might get some improvement. And it's not that TNA treatment removal isn't necessary. It's just, it's not the only piece of the puzzle.
It's part of the
So
picture.
it's part of the picture. And then, okay, but because we had a lack of proper nasal function, we had low tongue posture, that child didn't grow craniofacially like they should have. So now you have a hiccup in growth and development. You have a TP'd palate up into the nose. We don't have room for the tongue. We don't have good function. The tongue's falling back. So
Yeah,
you
this
have
is where
all these
tongue
things.
function, our colleagues that are big proponents of that, we have no training in that either, right? But we know that that's an issue a lot of the time too. It's
Right.
it's much more complex, and it just heralds the need for collaboration, collaborative approach.
Well, I think it would be great, and I know that they used to do this. They used to, we didn't compartmentalize the body like we do now, which is probably
Right.
an insurance driven thing. But we definitely have, it's like the body exists with all these compartments. You've got, you know,
Different modules.
all the different modules, and it's like they don't communicate with each other. And this whole human being, how much everything overlaps and how necessary it is. It would be wonderful if we could have clinics where everybody was in the same building and the patient didn't have to drive,
Yeah, who does that
here and
really
there.
well? The oncology community does that really well.
Mm,
Um, and at least here in Dallas, we're trying to build. So in oncology, let me finish that thought, then I'll talk about sleep. You know, a patient is typically seen by the medical oncologist, so the person that administers chemotherapy, the radiation oncologist, which is a different physician, if radiation therapy is indicated as part of the treatment, and then the surgeon, but also in head and neck cancer, at least the speech pathologist. I mean, so many different disciplines are meeting on regular bases, not just at academic centers, but at community hospitals too, and jointly deciding the best course of therapy for the patient. I always thought that was brilliant, and it would work in any disease state, but in general is just done in oncology. So what we're doing in our community here in Dallas is we're trying to put together that in oncology, that's called tumor board. So when you meet, you present patients and everybody discusses and you kind of come up with a collaborative plan. So in Dallas, we're trying to put together a sleep board
mm,
where we have the surgeons like me, we have the pulmonologist, the neurologist, the sleep dentist, we have psychiatry, we have so many different disciplines meeting. Right now we're still just kind of having introductory discussions about these topics, but our dream someday is to actually bring difficult patients and talk about them amongst ourselves and figure out what's best. So hopefully that's starting to happen, but none too soon.
well, it would be to add to that on my wish list. And I've talked to my partners in ASAP, Tracy and Michelle. We've talked about this, but more dice being potentially done to look at where the collapse of the airway is. My gosh, your ENT office or some oral surgeons would do it. Um, but I don't know how much are you doing dice at all to look for point of collapse? They're
For
not
those that don't
really,
know, yeah, that acronym is diagnostic sleep endoscopy. Um, Coming back to our friends at the insurance companies, it's very uh, hard to get those paid for, even if you're doing it in preparation for a potential sleep implant, like an Inspire implant. I hate to use brand names here, but right now that's the
right?
the main one that's on the market in the United States, at least. So, we always have to think about the economics. So what we do is a non-sleep endoscopy. That's part of most of our physical exams. I know you've had scopes. I've had scopes as well for my acid reflux. So we put a flexible scope through the nose. And what we try to do is have the patient snore, make a snoring sound, this, that, and the other. But most of the time, they're sitting upright in a chair and they're awake.
Right.
Does not remotely
Not sleep.
resemble what's happening when they're supine and they're asleep. Right. So, yeah, if we could do a dice on everybody that we suspect sleep disorder breathing, I think that would be really informative and go a long
Yeah.
way directing us on which mode of therapy would be the most successful.
Well, just, for adults, CPAP versus, an oral appliance. Is it a circumferential collapse? Maybe they
Right.
shouldn't have an oral appliance. There's CPAP, or maybe, oh, it's tongue based, it's soft palate. But for kids too, it's like, what are we seeing? Where is the collapse? Maybe we need to utilize more reverse pull face mask and have more sagittal growth and development help, to get that soft palate more forward. It just would be interesting to have that again on my wish list. But even drug-induced sleep endoscopy, that kind of it's still sleep, but it's not like real sleep because it's drug-induced. So it's better than them being awake, I guess. You're going to see that,
Yeah,
but
it simulates, it's better than nothing, right?
it's
It,
better than
it
nothing.
simulates, that giving that propofol IV somewhat simulates it.
Yeah. But you're saying, again, is it kind of a cash deal because not all insurance pays for that?
Yeah, and there's so many buckets to pay, right? That's done in a facility. Some physicians are real clever and are able to do that in their office, but most of the time you have to go to a facility, an operating room to do that. So there's cost for the operating room. There's a lot of cost for the patient, um, and it's not reimbursed very well. So the economics, I think, prevent a lot of that from happening, which is the reality of practicing
It
now.
is a reality which is why we're
There's,
having these conversations. I
right.
mean, it's like,
There's what we want to do, what we
right.
think should be done, and then there's what will actually get paid for. And I don't mean the provider. I'm talking about what the patient has to pay, what the hospital cost, et cetera. That's the
Well,
reality.
you had on your wish list that there would be maybe more dentists that would potentially be in network with medical insurance, or how do we have this continuity of care? So, you have dentists that are positioned and educated in sleep medicine and um, in the adult world, or the non-growing patients we call it, because we can do this even in a pediatric patient that isn't growing, but oral appliance therapy or mandibular
Right.
advancement device. So you've got a dental solution to a medical problem and a dental based solution. So, and then there's the hiccup, right? So it's not that the ENTs, and so we have a couple of obstacles. One, more, medical doctors ideally should be referring to sleep dentists.
Absolutely. Yeah.
But if let's say we answer that and all of a sudden they all start referring, we still have this kind of continuity of care issue where maybe the dentist isn't in network. And so now the patient's like, I can't afford that, or I don't want to do that.
Mm.
We talked about that earlier as well.
Yeah, here's what happened in my practice, right? And so I think, those that know me know I'm all about the medical dental collaborative for managing sleep apnea, obstructive sleep apnea. I think it is best practice. You're hearing it from the horse's mouth. I know lots of people ascribe different things to physicians about this topic, but I think the majority of us believe that having a sleep dentist involved is far and away the best care for the patient. Here's the reality. In my own practice, I've referred to the same sleep dentist for 25 years. He's absolutely outstanding. For the first 15 years of that, he was in a different geographic location. And so what I noticed is if I sent 10 patients to him, even though he's very good at explaining the rationale and, if you will, helping the patient feel comfortable with cost, all those kind of things, it still was probably only one or two that went forward with the oral appliance therapy. And oftentimes these are people that refused CPAP or failed CPAP. And certainly 20, 25 years ago, they didn't have much other options besides some invasive slash barbaric surgeries that were only temporarily effective, trimming the soft tissue,
Mm.
and long-term data is pretty poor on that. He, the dentist, actually came to me 10 years ago or so and proposed the idea of seeing these patients in my office. Now, again, there's legalities around all this. I practice in Texas, but by making him an independent contractor, so somewhat similar to my physician assistants or my audiologist, my allergy nurse, by him seeing the exact same patients in my office and as my delegate, at least in Texas, we're able to run those oral appliances through the patient's health insurance. So it becomes immaterial whether he's in network, out of network. This is a cash pay proposition, whatever, because the fact that they're in my office, we've already cleared the hurdle that I'm in network. And so the claim is run through me. Now, there's a lot of moving parts here.
Right.
In general, the patient is paying less, or even if they're paying the same amount, it's going towards their health insurance deductible rather than just cash pay, which they're just, you know, sending down the river. That doesn't count for anything. The dentist has to be properly compensated, but in a legal and compliant way. So what we do is we pay our dentist a flat fee. He's in our office 1 or 2 half days a week over the course of a year, probably 75 or 80 half days. And whether he sees one patient or he sees 10 patients from the 9 providers in my office, we pay him a flat fee. So there is no kickback per device, anything like that. That seems to be, at least in the eyes of our attorneys, the most compliant way, where the dentist can be compensated for his expertise, his work. The patient's getting the best care, not me fitting these appliances and trying to troubleshoot them, as we talked about. We have no real training in that, but the patient is getting the therapy in the least expensive way. And the physician, and since I'm billing for it, I actually am getting compensated too. So that seems to be the best way to do it. Again, every state has different
Right.
legality. So people have to talk to their own attorneys and see how this can be set up. I've seen other settings where the physician can rent space in the physician's office. Obviously, it's easy if the dentist can be in network with some of these providers, but that's a tough proposition for most dentists. Many of these networks are closed, and they're pretty hard on the dentists that are applying and trying to get in. We know that.
Yeah.
That's
Yeah.
the truth. So this seems to be a way to um, touch all the bases and get more patients, at least in oral appliance therapy. So that's, I guess, my wish list is for more dentists to feel comfortable doing that and for more physicians to feel comfortable setting up a relationship like that. It's for the sake of the patient.
It really is. It's a
People are not getting treated.
no, they're not. And oh gosh, I mean, the amount of people walking around with horrible sleep, horrible breathing, and like you said, the oncology world has this kind of nailed and figured out. And if we could find a way to definitely with convenience, with medical insurance, really kind of even speaking a more similar language. So, I had Dr. David McCarty on. He's a sleep physician out of Boulder, Colorado, and he has a clinic called Rebus Health. And they're looking at adult sleep, pediatric sleep. They're bringing in everything. And, it's having these roundtable discussions, if you will, once a week, looking at a patient with multiple professions input. And what you're starting to do is very progressive, Keith. And what it is doing too is it allows you to have a better communication with a sleep dentist and the sleep dentist to better understand where you're coming from. And the sleep dentist is telling you too, like, look, I would have done it on this patient, but maybe A, B, and C made it that they weren't a candidate for an oral appliance. And you're like, didn't know that. And, there's just things that need to be done on the ENT end. And I tell my patients, look, I'm kind of helping you from a little bit of the soft palate to tongue base. That's my zone. But this whole area, that's my ENT friends, and then even underneath,
Even
lower
below that,
the
yeah.
Malaysia, things like that exist, that's where the epiglottis folds over. I mean, that's my ENT friend too. So, we kind of overlap, our playgrounds overlap. So I need the ENT to help me fully help you breathe and sleep better. So
Yeah.
it would make more sense that more dentists and ENTs were collaborating that way. And who knows, maybe somebody listening will be brave enough to,
Well, it's pretty easy. I
you
mean,
know,
the call I actually had before we're recording this was with a large group of practices in the Northeast, and you just do it stepwise, right? So they're starting, frankly, with the screening and bringing the home sleep testing in-house. So they at least can learn about that, and they'll be shocked and see how many people in their waiting room that are there for hearing loss and chronic sinusitis and acid reflux or whatever. If you just screen them, we know, right? 20% of the planet's population is walking around with diagnosable obstructive sleep apnea, let alone every other sleep disorder too. And they're already in an ENT's office. I mean, what
Yeah.
a tragedy if I look in their ears and talk about their hearing loss and don't even ask them about sleep. And that's something that I emphasize. So we fixed that. We screen every adult. They get in our case, an Epworth sleepiness scale. A lot of practices throughout USENT will use a stop bang. And then you get that data, but you have to act upon it. So our medical assistants and our mid-level providers that usually see our new patients first, they ask about that no matter what they're actually scheduled for. And a subset of those patients merit home sleep testing, and then we're off to the races. We're identifying these patients. So that's the first step, screening and testing. Then you can get a little more sophisticated. Obviously, a majority of patients are going to need to try CPAP. Either they have severe OSA or, that's just the usual first step. That's obviously still the gold standard treatment for sleep apnea. But we know after 90 days, a substantial percentage
Hmm.
of them have already failed CPAP. And what do we do? Just let them go about the rest of their life and do nothing? Absolutely not, right? So those people need to be tracked, brought back in, and other options discussed, such as oral appliance therapy. That's, when a practice can become more sophisticated and not just, okay, here's the name of two good dentists in our market, but actually have a cohesive plan. Doesn't have to be like my model necessarily, but I have the quality control with my model. I know that patient's going to get seen by a high caliber person who knows 1,000 times more about it than I do. And then we're going to work together to get that patient treated.
And I think that's a big reason too. We see a lack of collaboration is I think there is a fear that when the MD refers out of the practice, they're like,
Yeah.
what's happening? Are they even seeing the dentist? Did they see the dentist?
Or are they going to come
Um,
back?
are they
Right.
coming back? So it's a paradigm shift, and it's like they feel like they kind of lost the patient into the Bermuda Triangle because
We
I,
certainly feel that way with CPAP, and
yeah,
even before we were able to do home sleep testing, that's how the otolaryngologist would feel. That we're sending this patient out, and we're never going to see them again.
yeah. Well, we feel that in dentistry too. We would
Yep.
send out for a sleep study. The patient came to us for oral appliance therapy. We'd send out for a sleep study, and then we'd never hear
Yeah.
back because
Yeah.
they went and just got a CPAP and we're like, wait a
Probably,
second.
probably failed that, and and
Yeah,
now
so
they're
we're
not
like,
going
what
to give
just
them much care.
happened here? But
Yeah.
I think too, it's shocking. So I'm listening to you because patients will say, I've been to two different ENTs and they told me nothing's wrong, or they seem to dismiss it. Or I've been to two or three different orthodontists and they said there was no issue, no reason to
Yeah.
intervene.
Yeah, I hear
The,
that too.
the problem we're having is we don't all speak the same language. So you can see five different ENTs. Not all ENTs are involved in sleep health, and
Mhm.
not all dentists are involved in sleep health. Not all orthodontists are involved in sleep health. And they're not all asking those questions and they're not all screening. So you might go to an ENT who's very focused on certain aspects of
Yeah,
structure and
sinus analogy or
yeah,
whatever.
and they blow past everything else and they've got this sick patient in their chair that they could totally help in other ways as a whole human being. You have dentists that are just looking at I call it the white things in the mouth. They just look at teeth. They might look for oral cancer. They kind of stop at the tonsils and the uvula. They
Right.
don't ask the questions.
That's
They
the end of
blow
my
right past it.
territory.
So
Yeah,
we do have
that's
an
where,
issue with
and I
screening.
know a lot of dentists will do sleep testing too, and that's another frustration for dentists. Again, if you're not in network, you're either asking the patient to pay cash for that test, or you as the dentist are eating the cost of that.
Right.
And so that's yet another reason, even just diagnostically, to collaborate, right? Because the patient can run that sleep test through their health insurance.
A
And even if
hundred
they're
percent.
paying out of pocket, like I said, at least it's going towards their deductible. And whenever a patient is treated, the follow-up sleep testing is just as important, whether it's a true PSG or it's just ongoing remote monitoring. And that's just, again, a long-term opportunity for collaboration.
Well, for any, and I'll throw it out here, an understanding of CPAP in children. Yes, CPAP is necessary. I have a lot of kiddos on CPAP, but CPAP as a long-term solution in a child, it has very similar effects to the maxilla and the growth of the midface, similar to what we call headgear in orthodontics, which they used to use headgear. Some still use it, but they basically, the big head strap on the head, and then it, had some hooks to kind of hook into an appliance and basically hold the maxilla. So it would stop the growth of the maxilla so that lower jaw would kind of catch up. But it was worsening an already existing problem. And we know that CPAP
Yeah,
it moves teeth in adults, which that's a side effect. Oral appliances move teeth in adults. That's if you need it, you got to breathe.
right.
It's just in the growing child to please look pat like just, oh, they're on a CPAP, they're fine. Well, if they're on a nasal CPAP, it literally has a headgear effect. It's taking a problem they might already have a
Yeah.
craniofacial problem, and now you're making it worse long term. So it's working with, okay, think outside the box. Maybe there is an airway dentist, airway pediatric dentist, or orthodontist that could. There are techniques with a CPAP on that rapid maxillary expansion or even slow expansion in some kids, but just expanding the maxilla while they're in the CPAP, we can see those CPAP pressures come down for these kids by creating more
This is
nasal
really
volume.
important information that most of us in the ENT community have never heard.
When this is, I just wish we would talk more and
Right.
you could see what is happening in our community and how we get kids off CPAP. And then they can get back on that normal growth and development track. But that CPAP is stopping the growth of their face. If they already have a problem, and we know, the research coming out, if they still have OSA after tonsil and adenoid removal, and they're not obese, but even in the obese child, still consider craniofacial deficits and hiccups, but
Mhm.
especially in the non-obese, BMI is normal, tonsils and adenoids have been removed. This is an issue of craniofacial deficits, and they need a dentist, a pediatric dentist, an orthodontist that understands this. So just having conversations and starting to ask around to other ENTs, hey, do you know of a good airway dentist? And some of the adult airway dentists that are doing oral appliance therapy or mandibular advancement devices, they may not be the ones doing the craniofacial or dentofacial orthopedics, but they'll help you find somebody. You
Yeah,
know,
I think it goes back to trying to replicate what we have in oncology, right?
right?
Where we ask around and who really emphasizes this, who has experience in this, multidisciplinary, and setting those networks up in your community.
100%. So we hopefully we can keep these conversations going and um, help more patients, Keith. I'm excited about the future. I do think 5 years from now it's going to look very different. It's changing fast, and I
There's
think
much more awareness and
yes,
commitment to it. I mean, you and I are on these kind of recordings all the time, and we've touched on a lot of things today that have never been discussed, at least with me. Um, so there's so much more awareness, and I think that leads to the solution eventually.
agreed, agreed. Well, I know you told me that you were gonna go make a pizza on your new. You've got a new
Santa brought me these wedges, so my instrument of choice is the big green egg. So, um, I've asked Santa for a pizza oven that's been denied repeatedly. So so now the best next solution was there's an accessory that you can kind of make your green egg a pizza oven. So it's hard to describe it without showing, but there's these wedges that you put on so the grill surface is circular and you can kind of prop the lid open so there's a mouth like a pizza oven. And you just get the fire super hot
Mm.
and you create that effect, the way the air is circulating, and then you can put the pizzas in there. So this is my maiden voyage of the pizza wedges on my green egg.
Are
About
you
to
going to have a video? Are you going to have this a
Yes, yeah.
review of it?
Yeah,
Good.
and if it's terrible, then they will not be
I think
posted.
it's good if you just show even the mistakes.
Well, yeah, those are usually my best posts are the ones where there's bloopers, right?
Yeah, I like the blooper
So,
ones. Those are
so
great. Those are great.
blooper may be about to happen, but you gotta start somewhere.
You got to start somewhere. Well, I can't wait to watch the video and see how that turns out. I would love to have you back and us keep these conversations going.
Absolutely.
And but before I let you go, I gotta ask my three random questions that have nothing to do
Oh, I'm
with anything.
scared.
I know, here we go. And let's keep this PG, but what was the last thing you Googled?
How to use the pizza. And that's true. You can look at my phone. I was watching YouTube this morning, looking at the experts, so I feel prepared.
All
But that,
right.
that's
All right.
literally true. That's literally true.
Okay, perfect. What is a totally normal thing that you never learned how to do?
Well, I'm starting to learn. I'm almost 54. Skiing.
Ooh, I've never
So,
been skiing in my life.
no, I advise you not to start. It's dangerous and frustrating, but I'm pushing through. So I'm there fighting through with all the 3-year-olds skiing next to me,
On that little bunny
like
on the bunny
like
slopes.
like doing circles around me, skiing backwards, taunting me.
They're
No,
fearless.
yeah,
They're fearless. Okay, and then the final question. What is your favorite go-to grilled meal? If you're gonna throw something on that grill, on that green egg, what is your favorite?
yeah. I cook a lot of beef, but my favorite on there is salmon. It's
Ooh.
amazing. It's amazing.
Yum. I bet it's super perfect and tender and flaky and
Yeah, it,
yummy.
it makes you look like you're a good cook. So you just throw that on there at about 400 degrees, 20 minutes. I mean, I've played with all these other techniques, but you kind of can't screw it up. I just wrap it in butcher paper. So I don't cook with a lot of aluminum anymore, aluminum foil right on the meat, just like I'm trying to eliminate plastics and all these things. But I mean, it's just incredible. It's flaky. There's a little bit of smokiness to it. Um, that's the
Yeah.
go-to. If we're having company over or whatever, the boss always tells me to throw some salmon on there, and it always turns out well.
Well, and when is this seasoning coming out of yours?
Well, it's not easy to get something on Amazon, right? Who knew? But I'm in the final stages of getting that approval. So hopefully, even we're recording this in January, so hopefully by the end of the month or early February,
Ooh, good.
it will be widely available.
Okay, great. And I'm going to post in the links. There's all these ways you, the listener, could get with Dr. Matheny for maybe a consultation. Maybe you're an ENT. Maybe you want to understand better about ENT partners. Maybe you want to understand better how to do the model that's working for him. Or maybe you're a patient that wants someone that's really progressive. So um, I'll have all those in the link. And we appreciate the listener for being here today and being open. And hopefully, we've helped somebody today, help make somebody's life a little bit better.
For sure. Well, thank you for this opportunity and for all that you do, getting the message out. And yeah, I'd be honored to come back and talk about this more.
Sounds good, Keith. Thank you, and we'll see all of you next time.
This podcast would not be possible without the inspiration of my dad, Daniel Becker, and creative direction and editing from the very talented Jason and Dane Becker, then Lydia and Judah Walker. To stay connected and keep the conversation going, be sure to subscribe to our podcast and visit our website at asappathway.com. And please remember, the information in this podcast is for educational purposes only. It's not intended to be used as medical advice or to replace your healthcare provider's diagnosis or recommendations.